today's program is part of what we are entitling Catalytic Conversations for the organization. As part of the strategic planning process, we are developing a series of conversations, a series of venues where we have the opportunity to hear from outside communities. We want to provoke and inspire. We want to surface some new thinking on key subjects. And this is one of the ways that we think that we'll be able to make our planning process as robust as it can be. We'll also have task forces, program evaluations, and value exercise. But this has the potential to be a really, really exciting opportunity for all of us over the next year to learn more from different perspectives throughout the healthcare and the non-healthcare sector. Now, we felt that services for kids was a great place to start one of these conversations. It's an area where CAMH wants to rise to the occasion. We do have an established program in the area, and it's one that we think will evolve really positively with the opening of our new Intergenerational Wellness Center and 12 new beds for youth concurrent disorders. It's also an area of emphasis for the province as actually the first component of a strategy for mental health and addictions. The title for today's conversation is Rising to the Challenges, Mental Health and Addiction Services for Children and Youth. And we couldn't have someone with more impressive credentials for our inaugural Catalytic Conversation. It's my pleasure to welcome Dr. Simon Davidson, a well-known expert in this field. Dr. Davidson's a child, adolescent, and family psychiatrist who serves as the Chief Strategic Planning Executive of the Ontario Centre for Excellence for Child and Youth Mental Health. He's the Medical Director of the Mental Health Patient Service Unit at CHEO, Children's Hospital of Eastern Ontario, and he's Regional Chief of Specialized Psychiatric and Mental Health Services at CHEO and the Royal Ottawa Mental Health Centre. Simon also serves as chair of the Child and Youth Advisory Committee for the Mental Health Commission of Canada. Now, CAMH is doubly fortunate because in addition to the many hats he already wears, Simon's agreed to co-chair one of our strategic plan task forces in this area over the coming months. Simon is going to be joined for the discussion by two of CAMH's leaders in our Child, Youth, and Family program, Dr. Joe Beachman in the center here, and Ms. Christina Bartha, our Administrative Director in the Child, Youth, and Family program at CAMH. So welcome to all of you. We're really looking forward to what you have to say. I think, Simon, you're first.
Good afternoon, everyone. Give it a shot again. Good afternoon, everybody's looking forward to the refreshments after the panel. It's really a pleasure to be here. I'd like to thank Catherine for her very kind comments. And it was wonderful to listen to your annual general meeting and hear the accomplishments of CAMH and the great pride that goes with those compliments. And in a way, I think it's quite right that we should be focusing on child and youth mental health in what hopefully is going to be your last annual general meeting in the old buildings, as I understand it. So I'm going to talk with you about where we are in child and youth mental health, where we're going, and then the challenge that I was given, which I appreciate, is my opinion of what positioning options I see for CAMH. So in the next 3 hours, so it's a pretty tall order, and I'm going to try to summarize the first two and focus a little more on the third point. I felt that because CAMH is such a huge engine, a huge successful engine, particularly in the domains, in terms of its quantitative size, in the domains of adult mental health, and qualitatively in child and youth and adult mental health, that it was important just to make sure we're all on the same page and that we all know about the plight of child and youth mental health in Canada and that we understand it better. So for sure, we know from really good research that more than 70% of adults living with mental illness have their onset at an age less than 18. So from that perspective, not rocket science, it seems to me that if we get it right, it meaning mental health and mental illness, right for our children and youth, we get it right across the whole lifespan. We also know that while, and Marianne, you and I debated this many times, I haven't shifted too much, and I'm sure you haven't either, but conservatively, very conservatively, 15% of our children and youth, community-based, random sample, are going to have at least one diagnosable mental illness. Most people think it's higher than that, and that does not even include those who have mental health issues, but those who have an actual diagnosis. And yet, probably not more than 1 out of 6 actually gets any kind of help for those problems. I say probably because that data is really old, and that was from 1983. We are also drastically under-resourced in child and youth mental health in this country. And as mental health professionals, I think we have to share in some of the responsibility of the problems of child and youth mental health, in the sense that the thing that we all specialize in and should not be proud of is that we specialize in the art of fragmentation. Fragmented services, the limited ones we have. So there's also positive things going on. The one is much better consolidation and integration. You know, I'm going to boast for 1 minute because I think it's actually today, 30 years ago, that I did my final exams at the Jewish in Montreal and became a psychiatrist, practicing child psychiatry though. So 30 years ago. And I didn't think in my lifetime that I would see the amount of collaboration between ministries as we're seeing today. And I don't mean 2 ministries, I mean much more like 4 ministries. And this has to continue, and also collaboration between many services. So, all of that said, we also know that child and youth mental health is in the media all the time now. The profile has shifted. And in many parts of this country, and certainly I can speak well for Ottawa, the demand for service has hit a surge. In Ottawa, since September of last year, we have a 100% increase in the number of children and youth showing up in our emergency room, and about a 60% increase in admissions, and often our bed occupancy is higher than 100%. And the hope is that all of the initiatives to destigmatize mental illness, and kudos to those very brave families, I just spent an hour meeting with one before this meeting, who have stood up and encouraged families to know more about the well-being of their children and youth. And if they have any concerns, to identify those as early as possible, get help as early as possible. And we know that the earlier we intervene, the better the outcomes are. So where are we going in child and youth mental health? Well, getting mental health and well-being, health promotion, illness prevention right early on, and having a full continuum of mental health services for our children and youth is one of the places that we must be going. There is more funding, you know. There was an announcement in the most recent Ontario budget for $257 million of funding in child and youth mental health over the next 3 years as a beginning to the new strategy in mental health in the province. And of that, there should be an announcement. I had heard it was coming out 2 or 3 weeks ago, but we still haven't heard it, for about $91 million of that 257 during the current fiscal year. What we need is sustainable, increased funding, and it must be incremental as well, but not to pour new money into a cadre of services that's not operating very well. What we need is a transformed system of care. And that system of care has to have extremely strong accountability. That system needs to be nimble and flexible so that if we're not hitting our targets, we can redirect the resources and use them in the most efficient manner. And above all, and congruent with the direction of the Mental Health Commission of Canada, that new system must be user-driven. It must be user-driven by people with lived experience, their parents, families, and caregivers. So now on to positioning options for CAMH as I see it. And just bear in mind, I'm an outsider. You can take it or leave it. I think in terms of positioning, the positioning is already underway. So what I mean by that is that you already have the decision to profile child and youth mental health at this annual general meeting. You already have strong outpatient and day treatment programs in child and youth mental health. You have some very specialized programs that have good reputations. And by the way, in child and youth mental health, there are all kinds of pockets of excellence. But you know what? They're among the best kept secrets in the world. So you do have some of those nuggets here as well. And what about what Catherine was mentioning before I started my talk? What about the promise of the new program? The new program that's going to have 12 inpatient beds and will have the capacity to serve 40 young people per year. So the beds are inpatient beds and the 40 young people are for a day hospital program in the age range of 14 to 18, but focusing on mental health and addictions. Remember what I said about fragmentation earlier? Well, you're working against fragmentation by having a mental health and addictions program. Kudos to you. It's enough that kids who have both diagnoses go to one of the doors and get told they have to get the other one serviced first. So you're going to be leaders in the field very quickly in this area, and that is absolutely wonderful. So now, what are some of the challenges I think you could position yourself towards? I'm going to say something I think you might find unpopular. I think that the way services are fragmented in child and youth mental health in the Greater Toronto area is a real major problem. The territoriality, the competitiveness, the duplication seems to trump what's in the best interests of our children and youth. And that's just not acceptable. It's not. So I think CAMH has a wonderful opportunity to be leaders and role models in promoting integrative services, bringing within child and youth mental health and addictions the various agencies together into a more integrated system, and also between sectors. For example, in our emergency room at the Children's Hospital, we know that while kids in care in our area represent less than about 3% of the population, about 35% of the kids we see in Emerge are children in the welfare system. We also know that if we go and assess kids that are in in detention in the youth justice system, over 75% of them are going to have, in addition to conduct disorder, another mental illness and or substance dependence. So one of my big hopes is that CAMH will lead the charge in bringing services to people in an integrated way that promotes continuity of care. Second area, I think you are ideally suited for, and that is because you are already doing mental health services for the full continuum of age, so across the lifespan. What about taking the lead in Canada in transitioning youth into adult mental health services? Bringing together mental health and addictions, and also the various sectors that are involved. I think you have an ideal opportunity there. And similarly, because of your lifespan focus, I think you could do something that when I asked the head of Owlin, his mind just seemed to spin and he didn't think it was possible. I think you can do this. And that is pay attention to the developmental age of children, youth, young adults, adults and seniors, rather than their chronological age. Can they move through the system based on developmental age rather than chronological age? The next, as you heard, I work at the Ontario Centre of Excellence for Child and Youth Mental Health. First of all, I'd like to really acknowledge the wonderful service and work and collaborative spirit that Dr. Joe Beachman provided us during our first 6-year term at the Center of Excellence. He was a very influential figure on one of our committees, and we really greatly appreciated that. And now, Gloria Heim is on the advisory committee, and equally, we're enjoying her input very, very much. I think there's an opportunity to strengthen further even the collaboration of CAMH and the Ontario Centre of Excellence. You're already engaged in a lot of evidence-informed practices. That is our chief mandate, bringing evidence-informed practice to the field of child and youth mental health. I think that you've embraced it already. You can work with us to help us to be a change catalyst. You can be a mentor, a leader, and a role model for others in the field. And that becomes especially effective, I think, if you embrace the idea of being a leader in integration. From a research perspective, there are a whole lot of things you already do, but from the neurobiological perspective, I think there are several areas. I particularly like psychiatry interface, neuroimaging, autism. I also think, as I've already said, in the addictions and mental health concurrent arena, you are going to be ahead of the game very, very quickly, and also in the development of future evidence-informed practices. And so I have just a couple more thoughts. One I've mentioned already, actually, and that is a challenge. Above all, you can be a leader in engagement and empowerment of people with lived experience, their families and caregivers, being centrally engaged not only in the development of their own care plans, but of the systems of care that are going to work for people. I didn't think I was going to say this part, but I think I will, come to think of it. Why are our clinics open from 8 or 9 o'clock until 4 or 5 o'clock? Because many of us professionals rationalize it and say, you know, youth kind of like to miss school. Not true. Some do. But many of them would far prefer to come after hours. I think there's a lot we can do to make services work for people. And I think you could be a leader in that. And similarly, in the integration of models of peer support with more traditional clinical interventions. So those are some of my thoughts about the positioning for CAMH with regard to child and youth mental health. I'm really excited to also be working with you on the strategy side of things, as Catherine was mentioning. And I'll also be happy if you think there's a role for me to play in helping with the positioning as it goes ahead. And so thank you for your attention. And I think, is Joe going to be next?
Somebody's glasses are here. Leave them there. Thank you, Simon. Thank you for your comprehensive overview on the state of child and youth mental health in Ontario and to some extent in Canada. Thank you also for your comments about the need to integrate across sectors, to integrate in our approach to services, the need to take a developmental approach, the need to think out of the box. I think these are important ideas for us to be thinking about and to include in our planning. I think you also captured some visionary ideas that are important for us as we plan going forward. I do want to tell you a little bit about the Child, Youth, and Family Program. The Child, Youth, and Family Program provides outpatient services to children and youth with mental health and substance use disorders and concurrent disorders across a wide age range and a spectrum of disorders. We have 10 clinical programs for children and youth. We have services for youth with addictions and concurrent disorders, mood and anxiety disorders, early onset psychoses, and others. We register approximately 2,500 new cases each year and provide 20 to 25,000 patient contacts annually. We train students from all disciplines, including medical students, psychiatry residents, psychology, social work, nursing, child and youth work. The Child, Youth, and Family Program is one of the pivotal training sites for psychiatric residents and medical students and fellows of the Division of Child Psychiatry at the University of Toronto. With over 60 registered students, the Child, Youth, and Family Program provides a wide range of training opportunities for students of all disciplines. The diversity of our clinical services and the expertise of our staff offers training experiences in common clinical conditions as well as unique areas in specialization. You've heard Dr. Davidson describe the state of children's mental health in Ontario and Canada and the high prevalence and the lack of resources to treat these children and adolescents. Let me give you some additional perspective with a particular reference to substance use and concurrent disorders. Substance use and concurrent disorders, substance use and abuse is common in adolescents. In the recent Ontario Student Drug Use Survey in 2009, reported that for youth in grades 7 to 12, that is 12-year-olds to 17-year-olds, 1/4 report using illicit substances, 2/3 reported using alcohol, and 1/4 reported binge drinking. We know that adolescent substance use is associated with significant negative consequences. These include school failure, violence or victimization, high-risk activities such as unprotected sex, driving under the influence, HIV infections, and premature mortality. 50% of youth in the mental health service sector have serious substance use problems. These youth would be identified as having a concurrent disorder. Half of the lifetime cases of concurrent disorders begin by age 14 and 3/4 by age 24. So the comments that Dr. Davidson made earlier about intervening in the younger age and having an impact through the lifetime is easy to see how true that is. Clearly, it would be hard to overestimate the need to provide resources and treatment and intervention for this highly vulnerable group. In the late 1990s, the Ministry of Health funded 5 child psychiatry inpatient units in the Greater Toronto Area, adding a total of 30 new beds. These beds were not intended for youth with substance use disorders or for youth with concurrent disorders. Instead, they were to focus on the general psychiatric disorders. Perhaps this was a legacy of the days of the silo approach when substance use and psychiatric disorders were treated separately and in different settings. We know there is a serious gap in services available to youth with concurrent disorders. Partly this is because it has not been a focus of training and only in recent years incorporated into the curriculum training in child and adolescent psychiatry. This lack of training is not unique, but really a reflection of the need for training providers in the Greater Toronto Area and the province and nationally. Recognizing this gap in services and the need for training, capacity building, and research, CAMH has over the past 10 years, as part of our functional plan and site redevelopment strategy, planned a further expansion of our service commitments to include the first dedicated and specialized concurrent disorders inpatient unit and day hospital for youth between the ages of 14 and 18. We hope this is the first of many, but it certainly is the first. In the summer of 2012, it's hard to believe it's just a year away, I can remember when we first started talking about this, it really seemed like a dream and one wondered whether it would ever happen, but you just have to look outside and see the buildings and you know that it's on our doorstep and it is really exciting. So in the summer of 2012, Child, Youth and Family will open 2 new services, including the Schedule 1 inpatient unit with 12 beds, as Dr. Davidson had mentioned earlier, and a day hospital with a capacity for 40 adolescents annually. The new services are being developed for concurrent disordered youth. These are youth who have both an addiction problem and a mental health problem. Youth from the Greater Toronto Area and from the province as a whole who need diagnosis, stabilization, possible medical withdrawal management, treatment initiation, transition planning, and coordination with community services. It's critical that this unit fit within the continuum of care and that we work closely with our partners across the city and across the province. The day hospital will provide treatment and academic programming for youth who are able to live in the community and travel to the hospital on a daily basis. Stepped care plans will be used to provide stabilization and prevent admission to the inpatient unit where possible and facilitate transition, aftercare, and discharge from the inpatient unit. In addition, the launching of the new service was viewed as an opportunity, as a possible catalyst, there's that word again, catalyst, for a broader planning process for a system of services for concurrent disordered youth in Toronto and the province, in which CAMH could play a pivotal role as a leader or participant in an action-oriented group that would meet regularly to plan for a network of integrated services for youth with concurrent disorders. This doesn't exist currently, but clearly there's a need and an opportunity to take a leadership role in this area. A major focus of our research efforts are directed towards youth with concurrent disorders. We've been supported by a 5-year, $1.5 million grant from Canadian Institutes of Health Research. In addition, Health Canada is supporting a national initiative to enhance service provider concurrent disorder capacity, to increase early intervention opportunities, and to improve pathways to treatment for youth and their families. The confluence of our recent success with external peer-reviewed funding, our local, provincial, and national presence in capacity building, and our planned opening of the new services positions the Child, Youth, and Family program as a key leader in clinical service, research, teaching, and capacity building. Recent consultations with over 30 community stakeholders has reinforced the importance and the relevance of this work and the support for CAMH and the Child, Youth, and Family Program in taking leadership in this area. These are major, exciting new developments for the Child, Youth, and Family Program, for the children, youth, and families of Toronto and the province. Thank you very much.
Thank you, Joe. I am going to try to go quickly through my comments just to ensure that we have sufficient time for questions from the audience. And I'm going to frame my comments a little bit differently. I'm going to talk a bit about what our three major commitments are as a program going forward, especially with our new services for youth with concurrent disorders. And I'm really hoping, Simon, that they reflect some of the opportunities that you outlined in your remarks. The three commitments that we have going forward as a program the first one is a commitment to consultation and engagement with stakeholders, especially the users of the system, the children, youth, and families that come to our program. The second is capacity building in the area of youth concurrent disorders. And the third is a commitment to collaborations, partnerships, and integration. And I just realized that my bifocal glasses don't work so well unless I hold these pages up. So forgive me if I'm going to hold these pages up. When we made our commitment to grow our services in the area of youth concurrent disorders, we knew that we had to consult. And so in 2007-8 and in 2011, in total we held 4 community consultations to obtain feedback on the vision of our new services and to get very direct advice on our operational planning. So we got feedback from over 40 people representing hospitals, child welfare organizations, children's mental health, and youth addictions agencies. The feedback was very positive about our plans going forward. We were seen as addressing a gap in the system, complementing what already existed, and the use of the new beds is anticipated to be quite strong once they're open. There was a lot of discussion about transitions into the beds, transitions for youth who are 18, out of our services and into the adult services, and the need for us to plan around critical points of transitions where youth and their families can so desperately fall through the cracks. And I'm pleased to say that we've taken that advice very seriously, and it has heavily influenced our planning, particularly between our program and our own emergency department, as well as how our program links and integrates with other providers in the system. And stakeholders told us as well, you're not finished yet, CAMH, you need to keep consulting. And we have a commitment to continue to do that, and we have other stakeholders that we have yet to consult with and intend to do that over the next few months. As a child and youth serving program, we also recognize the importance of ensuring that we hear the voices of parents and youth as they come into our services. When we were designing our buildings, we had focus groups and reference groups with parents and youth. I recall specifically when youth did not choose the same paint colors that I would have chosen for the unit, but they made the right choices, I did not. And we're planning on setting up an advisory committee and a youth reference group going forward as we conduct our operational planning over the next few months. Another major commitment we have is to capacity building. In anticipation of opening our new services, the program has invested heavily over the last few years in building our expertise in the area of concurrent disorders. We have now got cross-sectoral partnerships. We're collaborating with education, other hospitals, youth service providers, and they have taught us a lot about the work we are doing, and we hope to be contributing to the field as well. In that regard, since 2007, our staff, 2 of them who are sitting in the audience, have contributed to over 125 capacity building initiatives across the province and the country in the area of youth concurrent disorders. And the feedback to us has been, keep doing it, do it more, and continue to invest in training, knowledge transfer, and research in the area of youth with concurrent disorders. Finally, I want to comment on the importance of partnerships, collaborations, and integration, which is of critical importance in our very fragmented system. We know that our new services at CAMH will be only a part of what is a very important continuum of care that children, youth, families, and caregivers need in this province. And collaboration, partnership, and integration will be a major success factor for us. Over the past few years, Child, Youth, and Family has developed good cross-sectoral linkages through our memberships on a variety of networks, committees, and working groups. And we know that these will be very important to our current and future planning. It's through this joint planning and collaboration that we will be able to make the biggest contribution in terms of excellence in clinical services, research, and the teaching and training of practitioners in the field. At the center of all this activity is our commitment to work toward providing excellent coordinated services for children, youth, and families. And I know that for all of us in this field, this is our shared and collective goal. In particular, I want to talk just a minute about transitional age youth because it's a very hot topic in Toronto, and we're very keen to be part of that conversation and to contribute to a dialogue that will better integrate services between the child, adolescent, and adult sectors. And I think given CAMH does provide services across the entire lifespan, we are uniquely positioned to make that contribution. So with that, I'm going to thank you and close my remarks. And I think we have about 15 minutes open for questions and what I hope will be answers. And I'm going to be, I guess, your MC for that portion of the this portion of the meeting. So I'm going to invite any of you or one of you to open things up with a question if you have one. We have a hand over here.
So thank you again, and pleasure to hear from you again. And I appreciate your passion and vision in reforming the child and youth mental health system across Ontario. We live in a child and youth mental health system that's fragmented, it's underserved, it's under-resourced. And again, I echo the comments of Catherine around the fear and the anxiety around the funding announcements and how that's going to be rolled out. We've heard twice that the announcements have been recalled. There's lots of tug-of-wars around all this funding. And how is this going to get to the systems and the services and the kids that need it? How are we going to repair our fragmented health system? Child and youth mental health services are health services, yet they're not funded or even integrated into the health system. They're not integrated into the hospital system. They're integrated into the social service system. But again, it's just completely fragmented. Concurrent disorders in Northeastern Ontario, we've started an initiative on the ground floor to try and talk about it, to try and work together, but there's really no impetus. There's too much tugging and competing for those scarce resources, and the people that are suffering are the people with the problems that aren't getting served. We also struggle with a system that seeks services from private for-profit enterprises, and tons of our resources get sucked into those private for-profit providers because it doesn't exist within a publicly funded system. So I'd like your comments, if you have any, about the private for-profit services and some solutions around how we can reform that to a publicly funded system that would be available for everyone.
You said a lot of things that I agree with. I was going, yes, 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 yes. There have been recently 2 major initiatives on mental health strategy in Ontario across the lifespan. And I really don't know how many before that also weren't implemented. So I think that there's a lot of really good work in there. I know that I had the privilege of being part of the early identification, early intervention theme group, together with Kwam, who was terrific in that endeavor. And I think that the outcome of that was a wonderful paper that really, if implemented, could solve a lot of the problems that you're talking about. I guess what I'm sort of saying in a roundabout way is that many times around, there's been fantastic work, really good papers put together, and there seems to be a lack of traction in the implementation of those papers. I don't think we have to reinvent too many more wheels. I think we just need to move forward. And it really ought to be nonpartisan.
We have a question here.
Thank you. I'm glad to hear you talking about early intervention, but my question has to do with prevention, and in particular primary prevention, and I'm wondering what are your thoughts on that in terms of an integrated and a comprehensive system to support all children and youth?
Well, picking up where I just left off about it ought to be nonpartisan, if ever anything ought to be nonpartisan, it should be a long-term vision that not only adheres to primary prevention, but addresses wellness, health promotion, illness prevention, and then embedded in that, there's an opportunity to identify young people that are in trouble really early and intervene really early. I've had the privilege of working in the YouthNet program, which has been in existence since 1993. And we have a database of 20,000 youth. And when you ask youth, if you think you have a mental health problem, who do you talk to first? There are significant differences between males and females. So when you ask males that question, about 35% of them say first they talk to no one. If they think they have a mental health problem, they think they've got to handle it themselves. And then their friends, and then their families, and all kinds of professionals, including guidance counselors, are a very, very small segment. And if you ask young women the same question, the last part of the continuum is exactly the same, but first they'll talk to their friends, and then they'll talk to no one. So all of that said, a philosophy that really increases literacy among the peer group. Not so, we've got to be careful. Things like mental health first aid is excellent, but only to be used appropriately. What I mean by that is if you take a course in CPR, it does not make you a cardiologist. So if you take a course in MHFA, it does not make you a counselor, but it allows you to have increased awareness and to be able to recognize problems and patch people to appropriate services. And that just gets, I think you've got to look at the full continuum so that if you identify people early, many more people are going to show up for service. A lot of people say, we can't do that. That may be true. We don't have the resources, but we've got to bring on the crisis in order to get the resources. So I don't think that's a good reason. So I am very strongly in favor of health promotion, wellness, and early intervention. It has to be a long-term strategy, and it also needs to be absolutely centered among people with lived experience and their siblings. Another group that we always overlook are siblings, and the impact of mental illness on siblings is profound, and if ever there was a place to do wonderful prevention, that would be a good place, and that should have actually been in my talk. I forgot to add it.
I'm Jennifer. I'm coordinator of the Empowerment Council, which is the voice for clients at CAMH. You have an email cluttering up your no doubt overladen inbox about this, Chris. We're currently participating in an inquest into the death of a youth who hung himself in SILAPS, which is a detention center for youth. And I think recommendations coming out of the inquest might be relevant to the services that are developing at CAMH. And I'm wondering if the services are going to engage at all with youth having issues with the law. And I also wanted to thank all of you for mentioning the importance of user involvement in developing the services.
Thank you for the question. We will inevitably see youth who have difficulties with the law. Youth who are involved in substance use and concurrent disorders frequently interact with the legal system, with the law. So we currently do provide assessments and recommend and provide treatment, and we most likely will continue to do that with youth who are involved with legal issues. We are not set up to provide long-term inpatient treatment for youth who are legally incarcerated, but we can provide consultation, diagnosis, and work with the youth and their family and other providers.
Okay, I'd like to try to squeeze in two more questions before we have to wrap up. So we have one over here and the gentleman at the back as the last question.
I just would like to repeat the question. My question is related to mental health needs and problems of immigrant, refugee, and newcomer communities. How the system would respond to that? And does anyone, for example, know how many war traumatized kids we have here in Toronto, the city that is home of about 80,000 newcomers on a yearly basis, coming mostly from war and coming from different cultures. How system would work with that? Is there any thought about that? I would appreciate your comment. Thank you.
I actually think you've got someone in the audience who can answer that a heck of a lot better than I can. Kwam, do you want to take that question? Well, thank you, Kwam.
I'm not really taking the question, but I will be able to say I was really thanking Simon for the fact that, as he said, he's going to be part of the theme group for the strategic plan. And because of the importance of ethnocultural diversity with regards to how we develop those services, one of the themes that's going to be taken up in the strategic plan through the lens of children and youth is going to be health equity. And it's going to be looking at how we can hardwire these sorts of ideas into the development of the new services. Because as you know from the Toronto District School Board, over 70% of children in Toronto schools are either first or second generation immigrants. And so any service that's going to be offering competent care in the Toronto context is going to have to take on the issues of trauma and of immigration and of racialization of youth as being sort of fundamental to the service plan. So the answer to your question is yes, it's on our radar and it will be part of the planning going forward.
Okay, and I think we had one last question here at the back.
Thank you. Dr. Davidson and Dr. Beachman, I really appreciate, I'm Stephen Carter with the International Schizophrenia Foundation, really appreciate all the effort being done at CAMH, the integration of services and the trying to work against the fragmentation. We haven't talked very much in this brief meeting, but I would like to introduce the idea of what services are actually being delivered. Accessibility and integration is fantastic. But I'm wondering if the programs at CAMH and on Ontario East are considering the elements of diet and nutrition, in particular with children in the area of early intervention and prevention.
Absolutely vital in terms of learning adaptive coping mechanisms. And so the earlier you learn those, the better off you are as well. And in fact, if I can say just for a second a bit about the YouthNet program, that's a program that is completely driven by youth ideas. And it's kind of interesting that you raise that because in addition to our focus groups and presentations, which also were youth-driven, youth came to us and said, when we're stressed out, we like to exercise. And so we asked this particular young woman what she had in mind. And what she had in mind was developing what was called Healthy Body, Healthy Minds, a new initiative in the mid-90s. And her preference was snowboarding. So we taught her how to fundraise, how to negotiate with a ski hill and all the rest, and transportation and so on. And she taught us a ton. She told us when she takes the 50 youth up to the ski hill once a week for 6 weeks in the winter, it mustn't be all the same youth. So her mix was a third of them should be from the school system, a third of them should be from the traditional mental health service. Anybody want to guess where she said the other third should come from? Homeless youth. Imagine that. A third of them were homeless youth getting back into the mainstream through exercise. And she also said, you can't give this to all these youth for nothing. So we charged them, in line with what she said, a couple dollars a week. And then youth came and said, you're discriminating. So they had another idea, that not all of them dealt with their stress through exercise. Some of them liked the creative arts. And so Pens and Paints was born, again, youth-derived. And then youth said, we can't snowboard in the winter. And that's how Take a Hike was born for the summertime. And so, in fact, when you ask young people what they need, they come up with fantastic ideas, very centered around your question around exercise. They haven't gone yet to the whole area of healthy eating, but I think it's not that far behind.
Okay, so I think that we're going to wrap up this portion of the meeting, and I'm going to hand it back to Catherine.
So thank you to all three of our panelists, first of all, for the information that you provided to us and for the stimulation of the questions and for your excellent insights in the form of the answers. Specifically, thank you to Dr. Davidson, who traveled here to be with us, and we're really looking forward to working with you as we go forward with our strategic plan.